have all of you mental health experts around the country all gathered together. We're going to change the world. We have to be disruptors. We have to change how things have been going.
If it's too much about pain, boy, it becomes overwhelming. If it's too much about hope, it becomes propaganda. What's really spreadable, and it is spreadable, is courage. But the only stories we've told are those who've tragically lost their battle. We've not told the stories of those who found a way forward. We want to spread that courage.
I think the thing that struck me the most is the universality of the messages from people with such diverse backgrounds. I mean, you got a kid that grew up in Indiana, you got a guy from Oakland, you got a girl who lived in Miami, and it all came down to like two things, I think: connection and purpose.
The bigger picture for all of us as Americans or around the world is the stigma and how we look at suicide and people that are struggling with suicide. And I think that has more importance than anything else. So it needs to get on Netflix. It needs to be spread around, go viral. Everybody needs to see it.
Phenomenal opportunity to be there in Salt Lake City, and we're going to get started here in just a second. Welcome to episode 229 of the Crisis Jam. I'm David Covington. I'm your host today. I'm the CEO and President of Recovery Innovations, a managing partner at Behavioral Health Link. And our team is so excited to bring another episode focused on the terrific work coming out of Salt Lake City and out of the state of Utah. Rep Steve Eliason and Kevin Curtis, they welcomed us into their home back 4 months ago now when we did our first live and on location event with the new Kim and Carolyn Gardner Crisis Care Center. A really amazing example of what communities can do to get people to care immediately in a mental health or substance use emergency. We're going to hear from Rep Eliason and Kevin Curtis here in a moment. Rep Eliason was just asking me, so is there a separate link for panelists? How do I get in? Well, we're all panelists in the Crisis Jam. That's the reason we go through the Zoom authentication. But it makes it important that we all follow our etiquette here. There's a couple of hundred of you here. There's more on the live stream on YouTube. And please keep yourself muted unless you're jumping in to speak. The experience is really designed around the speaker view. You'll get gallery view if you don't go to the upper right and click in Zoom for that full experience. And join us in the chat, share your thoughts, tell us where you're from, ask questions. There's a whole separate experience going on in that chat for those of you who are there. We're looking to expand that same experience and for those of you who are jumping on the live stream on YouTube as well. Our new ASL feature is right there in the lower right, gives you an opportunity to add that and customize it in ways that wasn't available in our prior iterations. You know, I remember back, it's been decades ago now, when there was a handful of us who went to both the American Association of Suicidology conference, where crisis leaders, crisis workers gathered, and the National Council for Mental Well-Being. Those two conferences, those of us who were in both of those, Phil Evans, Leslie Levin from what is Behavioral Health Response out of St. Louis today, and how far we've come in this marriage of states, crisis organizations, lived experience, national organizations, national leadership. And in the Crisis Jam, we have this learning community that's not just thousands of you who gather in, but we're approaching 600 who've actively shared their experiences, their work, their perspectives into the community over the 229 episodes we've had. And we're still always looking for hot topics, featured speakers, new segments. Let us know. But if you see your name on one of these, we've now spread it to 2 pages, the nearly 600 of you who have participated as a panelist, answered a trivia question, given a featured presentation on the Crisis Jam. If you don't see your name there, let us know, and we would love to work you in, or your state, as we go forward. For the last several seasons, talk.crisisnow.com has been the go-to location. We'll continue to host that for some time, but we will be launching a brand new URL for Crisis Jam, starting with season 6, coming up in just a few weeks now. But for now, talk.crisisnow.com gets you to the live stream, the Zoom, our newsletter, as well as all of the past materials. Terrific episode. The first time Dr. Jonathan Singer had ever been a speaker on the Crisis Jam was last week. He's a tremendous leader in the social work, suicidology, youth mental health, and it was great having Shelby Rowe do a fireside chat with him. Not only talk.crisisnow.com and the new website that we'll be unveiling soon, but our YouTube channels. We have a 988 channel. I have the 5 Lanes to Recovery channel that have all of these materials and more. And we're now color coding them to the various levels of engagement, our debates, live and on location events, day in the life, fireside chats, and our usual featured presentations. So like and subscribe those channels and those videos. And a lot of this will come out in season 6. We've been teasing this a little bit. SAMHSA's been an amazing partner and sponsor of the Crisis Jam for the last several years. That funding will discontinue at the end of this fiscal year, which is the end of this season, with the new year starting here as we go into September and October. So season 6, we've got some new sponsors which are helping support our Crisis Jam going forward. More about them as we go. But for now, I want to give you a sneak peek. We're going to retire that 10-9-8-7-6-5-4-3-2-1 intro to the program. We've got a new quick spot that Dr. Chuck Browning voices that we unveiled at the NASBIT annual meeting, and I'll share it with you now.
From the living room to the Senate floor, from first responders to technology innovators. Different roles, different stories, but one goal: to meet the need for crisis care and overcome the obstacles together. So join in. The Crisis Jam is starting now.
So still tweaking on that, but we'll have that ready for our September episodes as we go into season 6. And we've got a host of new kinds of content that we're going to be bringing to you. One of the ideas that came out of the NASBIT annual summer meeting was a discussion that Richard McKeon and I had with Senator Tina Orwell from Washington State and Rep. Steve Eliason from Utah. We're affectionately calling this the Battle of the Bills, but both these amazing leaders are battling for better mental health care, for better crisis care, for better responsiveness. And we're going to have an episode coming up. We're still working on how to do that live and on location or other kind of an event that they'll be sharing turnkey legislation. Think the NAMI and NASBIT model legislation for how you fund 9 and 8 using a fee. They will have a host of different bills that the two of them have passed or attempted to pass over the years that you in your state, if you have a legislator who's into mental health, substance use, crisis care, they could come and hear 15, 20 ideas, my guess is, will come out of this battle of the bills coming in season 6. The other thing that we'll be doing in season 6 is pairing that with a global event. We have hosted 9, this will be the 9th global event that we've done over the course of the past decade plus. Last year, the Crisis Now 3 Summit was in Amsterdam. We had a host of you join us both from the US and around the world. And we're going to be having Crisis Now 4 in Washington, D.C. in conjunction with the NASBIT annual meeting. So the NASBIT annual meeting will focus on that July 26, 27, and Crisis Now 4, July 28th and 29th in the same complex, same facility, back to back, and again, partnering with Global Leadership Exchange. So we hope you'll mark your calendars. If you're part of NASBIT, that July, I believe 25, 26 and 27. And regardless, we invite you to join us at the Crisis Now 4 Global Summit on July 28th and 29th. We had t-shirts for a while and have sort of moved away from that, but with season 6, we're going to be resurrecting our Crisis Jam shop and a new refreshed model. We're looking for you for your ideas. We've had the historically the whatever the SAMHSA official branding was for 9-8 available, but we'll be expanding that to a host of other ideas, and I'm going to give you a sneak peek at that from our team. Mic drop for Crisis. All feelings welcome. That's the creative one. It's bleeding. The 9-8, no judgment, just help, 9-8 day. It's for everyone. Coming from our Oklahoma pioneers in the space. So more to come on, again, bringing back the availability of t-shirts and getting those into the mix. So I thought that was jam. Oh, yeah, right, Jessica. That I missed the metaphor on that, didn't I? We also, in the latest crisis news, Dr. Art Kleinschmidt, Principal Deputy Assistant Secretary for Mental Health and Substance Use at SAMHSA, visited Baton Rouge, visited New Orleans recently. And I'm going to show a little bit of this clip from Tanja Miles.
So many people who are here today, you understand the power of recovery. You understand the power of hope. We know that addiction does not discriminate from the curbside to the country club. It can affect all of us, but there is hope. We are in a crisis in our community, in our country. And it's the beautiful people like you, the people who are the therapists, the doctors, the peers, the people who do the work. Hey guys, what's up? So we are super excited today. Today we have Dr. Art Kleinschmidt with us today. He is the Principal Assistant Deputy Director of SAMHSA. Who is SAMHSA, you ask? I know y'all know, but if you don't, SAMHSA runs all the mental health and substance abuse for our country.
All that stuff that everybody sort of went through, the trauma, the grief, the pain, sort of the suffering, the stuff that maybe I'm ashamed of, how I behaved, all of that becomes an asset once you get into recovery.
So really a terrific visit, and I got the chance to see some of the peers talk about their recovery, to hear Tanja and Dr. Art talking about the miracle of recovery. You can see more about that on the SAMHSA LinkedIn page, where they have quite a bit of material related to those visits out in the community. Also in the latest crisis news, mark your calendar, September 8th, 9/8 is 9/8 day. Last year, that was a pretty spectacular event. I remember seeing a host of Monica Johnson and others, Jill Mays, and all kinds of creative content that was out there in a really viral moment around spreading 988. If you're with the 988 team with SAMHSA, we're going to be making an outreach, but we'd love you to come on and talk more about how we can activate. I know there's some webinars and other opportunities that we'll share more about. So that leads us into our crisis trivia for today. We're going to revisit the question we asked when we did that live and on location event in Salt Lake City. EMTALA, the Emergency Medical Treatment and Labor Act, was passed in 1986. What was not a reason for that landmark legislation? A, was it preventing hospitals from denying emergency care based on a patient's ability to pay? That's A. Was it B, stopping the practice of patient dumping, where unstable patients were transferred without proper treatment? Was it C, ensuring that pregnant women in active labor receive necessary medical attention regardless of their financial status? Or was it D, reducing overcrowding in emergency departments by limiting access for uninsured patients? Now, if you were in that seat, we'd give you a lifeline because the audience is, again, it may be the not sort of nature of the question, but a hint. EMTALA was designed to improve access to emergency rooms, not restrict it. And it's hard for us who were born and grew up in the post EMTALA world to think through when emergency departments were locked. But the answer is, in fact, D. Reducing ED overcrowding was not the concern. It was the fact that people were being blocked from getting into an ED, even if they were pregnant or had significant medical issues. We think of patient dumping happening to EDs, but before EMTALA, hospitals did patient dumping themselves. So this challenge of access is one that we're now looking at with mental health. And I think it was Dr. Margie Balfour I first heard talk about EMTALA in the context of a metaphor or an analog for crisis facility services, mobile crisis teams that you can get to directly, like ambulances and hospital emergency departments are accessible to everyone today. We did this amazing visit to Salt Lake City back in March, and Steve and Kevin, welcome. I'm gonna just remind folks of this amazing tour that we did to start. But just before we do that, let's see, actually, maybe I'll just move the slide quickly here and come back to this. Where's my slide? Yeah, let's come back to this one.
And we're so excited today to be able to highlight this amazing building. You know, as far as I'm concerned, this is one of the most important buildings to open in a long time because of the amazing work that's going to happen here.
Well, 2.5 years ago, David, as you know, Hope had a new number. Now, Hope has a new location. And you see what a beautiful facility it is. We think this is the crown jewel of the state and maybe the nation.
So Kevin, it's been open now going into 5 months. You're the leader of that program. Tell us how it's going.
Well, the old adage, if you build it, they will come, has definitely been true in our case. We have had lots of opportunity to serve our community through our various entry pathways. And it's been an immense pleasure to be a part of that process. We've learned a lot, we've adapted, and we still have a lot of learning to do. Just as a point in time indicator, our 23-hour stabilization area in the building is kind of set on a 30-chair model. The first day of our operation, we had 30 people come through that day. So utilization has been high. We have utilization coming from police pathways, EMS pathways, and a tremendous amount of utilization just by community members walking in, seeking hope and help with whatever their crisis looks like. So lots of good stuff happening.
So Rep Eliason, thanks for joining us. The one thing I would not have predicted is you'd have 30 people come through on day one. That's pretty remarkable. How's it going from your vantage point?
I think it's going tremendous. One thing Kevin didn't mention is one individual was waiting when the doors opened the first day, and he said he'd been waiting for months to come, and they actually had a certificate ready for the very first patient, so he was very happy to get that. But as a legislator, we set aside millions of dollars one time and ongoing funding for this facility, and to see that it's being heavily utilized is just a great sense of satisfaction. And the video you showed was when the facility was empty. Now as I walk through and I can see the faces, I can see people helping people in from the parking lot. Last time I was there, somebody walked up and said, "Do you think I can get help here?" Those are the really heartwarming stories. But we know we're diverting people from our jails, diverting them from our emergency rooms, and giving them a much more robust clinical experience than they would have if they were to go to an emergency room. So far, very happy.
Great. Kevin, I think Rep Eliason leaned into the answer with these last comments, but Megan is asking in the chat, where did these individuals go prior to the opening?
Yeah, so many of them were receiving care in emergency rooms. Some of them were being taken to jail booking because of the nature of their presentation. And many, almost 30%, are people that kind of indicated on where would you have gone without this program. They indicated, I don't know. So really nowhere, right? This has created better access through many channels.
Yeah, I think that's one of the questions that is always hard for us to get our arms around before one of these programs open is unmet need just gets lost. And when you actually provide the service that people need, then it begins to show up. Steve, David Huntsman talked in that visit about a lot of the funding that came into laying out the facility. But there's not just the facility, there's the ongoing operations. And you've done amazing work, extensive work, both with legislation and partnerships to fund the ongoing operations. We had intended to get to that topic on the tour, and we ran out of time. So lean into that, if you will, Rep Eliason.
Yeah, so just pre-COVID, back in 2019, I was in Nashville for a legislative conference and heard a presentation on the Crisis Receiving Center. They just opened there, and I quickly arranged an Uber and a tour, and they were great to accommodate me. And I built a relationship with the people there and learned from them. But I said, what are the major takeaways? And they said, look us in the eyes and listen to us very closely. There's a huge takeaway. Before you open your facility, get the commercial payers on board. They said, we didn't do that. And now we have a lot of patients being referred from, I think 5 major hospitals. They're not an expansion state. And so their funding mechanism was in jeopardy. So back in 2020, when I ran the bill that created a statewide network of crisis receiving centers and mobile teams, I first had in the bill a insurance mandate that all commercial insurers had to cover. It also required our Medicaid office to go get a bundled rate for crisis services, which they did and was easily obtained. However, the insurance folks didn't like the mandate. They usually don't. And so I took that out of the bill with the promise that they would negotiate in good faith to cover these services. Fast forward to 2025, and I think it was probably just a few months before we opened, the very last commercial insurer in Utah came on board voluntarily without the mandate. And I think that's really important to do it, if you can, voluntarily, because You have some insurance plans that are ERISA, some are non-ERISA. States can only impact one category, but we've been able through voluntarily working with them to get everybody on board. Now, mention one other thing, David, that was absolutely critical. You get the Medicaid on board through the bundled rate. You get the commercial and payers ideally on board through negotiation, because once they understand this is going to save you money on inpatient emergency room visits, they see the light. But the last category are the uninsured and the underinsured. So what we did in that legislation is provide $4 million of ongoing funding that helps to cover those costs. So we're truly no refusal. If they can't pay, then the state funding that flows through our county covers those individuals, and that is absolutely critical. So those are the three funding streams that we've really tied in and worked hard to get developed, and now are really proving their worth.
Well, that's terrific. As you describe it, there are cost savings that are generated by these approaches, and those do accrue to these same organizations according to the number of individuals they have in that mix. What is that mix looking like, Kevin, for you as you look at the people coming through? How does that break down relative to commercial payers, Medicaid, uninsured and underinsured? Do you have a sense of that yet?
Yeah. I'm going to see if I can do math on the fly, and these are kind of broad strokes numbers, but it's about 30 to 35% commercial, about 40% Medicaid, 20% are coming in with no identified funding source, and then about 5% are Medicare. Does that add up to 100? I think that does.
Yeah, we get a good sense of that. Chris and Paul are both smiling, so they may have some more on that as we get into that. I want to share my screen again and just talk quickly as we have this discussion of funding. Of course, we had a debate on the Crisis Jam with Hannah Wells-Zalowski and Tom Betlock. And the Crisis Jam community is really around this idea of states having a fee that is similar to the 911. But as we look at the states, we have now a dozen states which do have that fee. We have 5 states that NAMI recognizes because of their recurring appropriation is substantial without a fee. But when you look at per capita, Rep. Eliason, Utah is actually leading the nation at almost $11 per person to support this work, and it doesn't have a fee. So talk a little bit more, Rep. Eliason, at the global level, how that is working, and you're hopeful, even despite some of the restriction as we look at government and the new administration and spending. You're hopeful about the future. Talk a little bit about that.
Yeah, thank you, David. So a little quick brief history. Back when we tried to, in 2017, I ran a resolution to try to get a 3-digit number in Utah. We failed. So we worked with Senator Hatch, Congressman Chris Stewart, that got that passed through Congress. As they were working on that bill, Congressman Stewart came to me and said, "Hey, telecom doesn't like this fee, and I'm going to look at taking it out." And I pleaded with him, don't do it. States are going to desperately need that mechanism if their budgets are not in a position to be able to fund it themselves. And I said, stay strong, Chris. And he did. And now I'm grateful to see that map and see that it's working. But if states don't want to levy an additional fee or tax to fund it, and they can do it out of their general fund, it funds it just the same. I think that, where the source of the funds come from is not as important as that the funds are coming. And so that was an absolutely, critical component of ours, was the funding for not just the 988 Crisis Center, but for a warm line, which we created. So calls can be triaged back and forth based on acuity. We use peers to staff our warm line. That has been a huge help for us to triage calls appropriately. But then we also included funding for our mobile teams statewide, as well as approximately 8 crisis receiving centers from the extreme north to extreme south in our state. And, a lot of it's just educating legislators that this is going to help reduce our criminal justice costs. It's going to help reduce our Medicaid costs, and a whole host of other costs. And interestingly, I think some of our big medical centers that sometimes hit capacity in emergency rooms view this as a huge benefit, because now they can move patients out that are taking up valuable beds for trauma patients that are being flown in on helicopters. I was just talking this morning to an operator of one of our facilities that are located next to a hospital's emergency room. And he says, we literally wheel patients back and forth between our facilities based on acuity. We help them getting, behavioral health patients out of the emergency room that can be better served at our facility. And sometimes when we need inpatient beds that they don't have at their facility, they wheel them back over to the hospital and admit them. So whole host of benefits.
Great. Kevin, you guys stepped into this model of direct law enforcement drop off and cutting the middleman out of having to go to the hospital for medical clearance. How is that component of this working? And in fact, if I remember, you got a more of a traditional crisis facility. You then renovated and had a prototype, smaller facility, and you exited out of that facility. You were doing law enforcement drop-offs at that facility, and then you moved over to the new one. So those 30 people who are coming on day one, how many of those are coming from the back of a police car, and how's that working?
Yeah, so not as many as we would like are coming through those channels, through that type of drop off, whether it's emergency, like fire, EMS, or police. It comes out to about 15% of the total is coming through that channel. We are still working with our law enforcement and EMS partners to there's the cultural barriers. Most of the cases that they're bringing are emergency room diversions and not jail diversions. That's a tougher nut to crack.
Yeah.
In terms of convincing law enforcement that treatment is better than jail. But we've got good partnerships, and we're working on it and tracking it so that we can improve it. There is a really important thing that's come up in the comments about this operation side of things that I think is important to speak to. And that's that this process of learning, piloting, collecting data, and leveraging that towards the voluntary onboarding of commercial insurances, that was critical to our process, right? For most of our insurance partners, when we were able to go to them and we were able to have a conversation with our contracting team about, you're paying for this anyway. You're just paying for it with bad patient experience, bad outcomes, and high cost. So would you like to have a different option for your covered lives? Another important part to that conversation was we didn't undercut our value and really go in on the cheaper part. In mental health, we often undervalue our services. And because we undervalue our services, we cannot make them robust enough to actually function for real people in the real world. And so we weren't really making a cost-saving argument to the commercials. We were making an argument of better experience, better outcomes, reduced inpatient stays, and slightly lower cost. And for most of them, they jumped on board without any sort of stick needing. That the carrot was plenty for them. We had a couple of knuckleheads that kind of held out and needed a little bit more persuasiveness and stick-like conversations from the back end, but most of them came on board really willingly. But we cannot undervalue. Because we valued it appropriately, that allows us to do more robust medical screenings, and more robust medical screenings allow us to be more inclusive in who can be brought to us.
This is wisdom, guys. This is the gems that you're going to see in trivia questions coming up. A couple of knuckleheads, that's probably going to show up in a trivia question for sure. But these two concepts, Kevin Curtis, quote, stand in our value, quote unquote. The way we think about it is the savings are not in the daily rate. It's in the length of stay. But Rep Eliason, Kevin's leaning into standing in our value, making sure these programs are staffed and resourced for success with the level of acuity that we're targeting. to make a real difference. But the other thing he talked about is this return on investment. Chris Santasiero has a reference in the chat around a true cost webinar that Connections, Matt Miller and Dr. Margie Balfour will be doing. Paul, you were behind the crisis calculator, working the same space with Kana Inamoto's team. Steve, how do you think about, or how do you talk about with leaders in Utah? Do you quantify this, or do you put more to that idea of that there are real cost savings that come from the shorter, more direct meeting of people's needs in the moment?
Yeah, great question. So we're not far enough along to have really quantifiable data. We are tracking it, though. I spoke with Pam Bennett from the state this morning, and they're tracking the number of emergency room visits and inpatient stays, and we expect that we'll see those inpatient stays coming down, which, we all know Medicaid funding is under great strain with, a lot of the federal changes that have been happening. And even if there hadn't been federal changes, every state budget is always dealing with increasing, escalating inflationary costs in Medicaid above general inflationary levels. And so to be able to prove that in our Medicaid budget that we're seeing inpatient stays go down and less recurring visits, that's going to be absolutely critical. It's the intuitive part, though, is that, if people are going to jail anyway, the state is going to pay for it. The county, the taxpayers are paying one way or another. So why would you rather continue bailing your boat versus helping to plug that boat so that we break that cycle of emergency rooms, which Medicaid pays for, jails, prisons, which the state pays for? I mean, we've sold it intuitively and data from other states, but we look forward to the day when we'll have enough data behind us to show, yeah, we are bending the curve on costs for taxpayers. And the best part about it is we're doing it with better clinical outcomes than we did under the old model.
Love it. Kevin, we love the peach pit, love, loathe kind of questions. So you're running one of the marquee next generation crisis facilities in the country. What have you loved? What have you loathed so far?
We have loved, I mean, reflecting back on that video that you showed at the beginning, one, I kind of wished for snow to come back a little bit, because
that was amazing
out here, and it wasn't that long ago. There's something kind of nice and peaceful about the pristine of a new facility about to open. But I love walking in every day and seeing this building be used for what it was designed for. It was an intentionally designed building with a lot of thought, a lot of consultation, a lot of real attention to fine detail to make sure it wasn't just about treating crisis. It was about receiving people with warmth and compassion as a foundation for whatever comes after that. And so to see the activity, to walk in and see the people in the waiting room kind of going through the check-in process, to walk through the spaces and see them being used has been just amazing. Loathed, just building stuff.
Yeah.
You get into a new building and it's like, the Socratic idea of a door, the ideal of a door is that it's a thing that covers an opening and opens when you want it to and doesn't when you don't, right? And so why is it that in this case, this door is acting like a wall, right? Like we've had a lot of, while we're trying to provide good quality care, a lot of just working through all of the chaos of opening in a new space, in a new building, having things function the way they need them to. Personally, I'm a recovering perfectionist, so I've had a hard time not living in the details of the outlier kind of less than stellar outcomes. And so I haven't loved those feelings, but I've had lots of opportunity and mentorship and reconnection to therapy resources for myself to be able to really kind of live more in the celebration of the 99% that's just such an incredible benefit for our community. So
amazing. Well, congratulations to both of you. You're off and running. We saw it pristine, and now it's getting used. So let's go to Chris Santosiero first. Chris, you and I had a chance to talk with Rep. Eliason at the Nashville conference, and you guys are right in the heart of this work. What are you thinking, hearing Kevin and Rep. Eliason?
Number one, amazing. That's absolutely the approach that communities need to take. I'm the Vice President of Government Affairs at Connection, so I'm our advocate federally on the Hill and in the states where we've scaled this model to new communities. And I always say when there's an unmet need, there's a way, and these two guys, and I'm sure a lot of other people behind them have proved that is true, and it is doable. Let me double click on the this will now forever be known as the knucklehead legislation, that 5%, because we also firmly believe when we enter, serve people and operate the no wrong dollar model, that all payers should be supporting this service for their beneficiaries. It always comes down to and we have largely a lot of similar success in Arizona and Washington, Virginia, Pennsylvania, where we're operating no wrong door model crisis receiving centers. But what we hear from the knuckleheads is, well, if Medicare is not covering this, why should we? The other piece is the reality is, we are leveraging different codes for other payers. So with one plan may use S codes or G codes or inpatient codes or H codes, we're kind of like taking what they have available to them and kind of wrapping our model around it. And I would guess that it's very similar experience in Utah. So what Medicare coverage would allow is a more standardized set of codes to cover this service. So one of the things we talked about last week, and it was a wonderful conference, the Nashville conference, and it's always great to connect with like-minded folks and this vocation of crisis services that we all provide, is getting Medicare coverage for this service. Because I'd say we're at about 5-6%, maybe 8% if you include Medicare Advantage, Kevin, for Medicare, kind of similar numbers, but it's substantial because not only does it cover those lives, and in the reality is, like Steve said, Representative Eliason said, with the changes coming with the Medicaid reforms, like Medicaid's no longer going to be in state government dollars and local dollars are no longer going to be able to absolutely afford to cover this cost of care. It's intended for the uninsured. So I'll put the bill we're working on in the chat, and I'll pause there for a minute and
Thanks,
let
Chris.
everybody.
Awesome. Paul, Tom Betlock talks about a $2 savings for $1 investment. Tell us your reflections on this discussion.
Well, I think one of the remarkable things that stands out to me is something I've heard Representative Eliason say before, which is he talks about states are laboratories of democracy. And they found solutions as a state that work. And in fact, one of the things that always concerns me is, have we created sustainability within the systems that we're advancing? And if you think of the way this narrative started, certainly finding funding like Utah has done for 988 is an important piece of this. But then going after coverage that happens, and I always encourage states to look at what was described by Representative Eliason just now. It's the idea of you get Medicaid on board and you get a rate that's sufficient. Man, the way Kevin has described this as, you have to be able to provide care, not we have to cover the very bare minimum. This is about providing true health care that's meaningful to the person. And so when you get the rates right in Medicaid, and then you go and you get commercial payment in there, Chris is absolutely right that we want to get Medicare on board. But in the meantime, starting with these basic steps, when I've analyzed different states, you can reduce your state general fund, which is still, unfortunately, how many states fund crisis care. You can reduce that payment by 70%, something that's going to equip you when there might be changes coming to Medicaid over the next few years. How we're positioned to make this a sustainable effort is going to require getting all those payers on board. So remarkable work. The other thing I just want to note is, Kevin, when you did that initial video on site, one of the things Kevin talked about, he used the old term that was used in SAMHSA, the crisis receiving center, but this place of receiving someone, this analogy of the door, not only welcoming them, but I think you used a warm blanket as this example of, man, that's the feeling that we want to have when people come and they really, in a very challenging time, say, please provide some support. So a big salute. And I would also encourage others to watch what Representative Tina Orwell has done in Washington in the same way, to say, look, these states are laboratories for democracy. There's lessons to be learned that many of us can prepare for to have sustainable systems in the future.
Great. Thank you, Kevin. Thank you, Chris. Thank you, Paul. Rep. Eliason, last comment from you. Richard McKeon and I had the privilege to see a sneak peek of the Battle of the Bills that we're going to do with you and Tina Orlaw. Give people a teaser of what that's going to look like.
Well, there's going to be we're not going to have enough time. I can tell you that right now. We're going to have more content than you'll give us time. So we're going to have to talk like auctioneers, but we'll make sure that we deliver bipartisan bills that are a mix of bills that do require funding and other bills that don't require funding.
Yeah.
I mean, believe it or not, there's bills out there that don't need to have funding that can make a big difference. And so I think there's a line from the artist Sting that says we share the same biology regardless of ideology. And I think people will sense that even though we come from different colored states in terms of red and blue, there is huge consensus around saving people's lives, reforming the system, saving money, and better outcomes. So I'm looking forward to it. It's going to be it's not going to be a contentious debate. It's going to be about how we battled in both states for better mental health.
So, Richard, our concept is turnkey concepts that other states can take and use in their own legislation. Over under, Richard, how many tangible bills are people going to take away from this Steve and Tina battle? What do you think?
I'm going to say 6.
6. Over or under, Steve?
There'll be more than that.
Yeah. I'm thinking at least double that, but we'll see. It's going to be exciting. Richard, SAMHSA update. Glad to have you. What are you thinking about as you reflect on 5 months into the Salt Lake City experience?
Well, it's great to be here, and again, as you know, SAMHSA has had a effort going back for several years to the work of Anita Everett and Eleanor McCann's Cats in making sure that there was someone to talk to, someone to come, and a safe place to go for help. And, for this receiving facility, state of the art, starting in Salt Lake City, but also happening elsewhere, is such a critical component to that for implementing the vision of transformative change that SAMHSA has been supporting. So just absolutely wonderful to see. And Steve, I knew you have many more than 6. The question was, how many would people take away from it? And I don't know if people can come away with 10 different ideas. I'm sure you'll give it to them. But, sometimes the reason a 3-digit number is good is because 7 is hard to remember, or 10. So that was why I said 6.
Well taken. I'm going to underpromise and hopefully overdeliver.
All right.
As well as Tina. Yep.
And I did get contacted by a colleague at the National Council for State Legislators meeting who sent me a picture of exactly what we're talking about, the model of someone to call, someone to come, and a safe place for help being presented at that conferences. And I suspect that either you or Tina may well have been involved in that.
Ironically, that session was just this morning, Richard. So, but they didn't involve either one of us, but it was great to see reps from other states stepping up to talk about what they're doing in their areas.
Great. So, David, I just have a couple of other things as a SAMHSA update. We heard earlier about the 988 Day on September 8th. So please be aware of that. The theme is compassionate help, anytime, anywhere. Details and a toolkit are available at https 988lifeline.org/988day. And I'll put that into the chat. Also, want you to be aware that September as a whole is Suicide Prevention Month, and the Suicide Prevention Branch at SAMHSA has been working on a Suicide Prevention Month toolkit that we anticipate being released in late August with social media graphics, draft social media points, and new resources. So that'll be coming soon to the SAMHSA website. One other thing to let you know about this week, SAMHSA's Service Member Veterans and Their Family TA Center has worked together with the VA to put on a conference on suicide mortality review. This is part of a major investment that the Veterans Administration has made in trying to improve suicide mortality review, not only for veterans, but for all Americans. And there have been multiple conferences on this, and this was a summit bringing together all the state teams that have been working on this. So thanks for the opportunity to do this report out, and great to see you, Steve.
Terrific, Richard. Thank you so much. Now let's go to Dr. Jessica Pollard, who's been accusing me of delaying our upcoming debate so I would have more time to prepare. A ridiculous assertion, by the way, Jessica. This debate will happen by 2027 for sure.
Well, the facts don't lie, David. I feel like we're on our third postponement here, so you draw your own conclusions, audience. So I want to highlight a couple of things for our NASHBID update. Besides trash talking David, we are winding down our serious mental illness training and technical assistance center. So if you've been thinking about putting in a request, you've got some ideas and you just haven't hit send on that request email yet, please do that by August 29th. And we need to get our technical assistance on that center wrapped up by September 9th. So our fastidious Day Catalano will be putting all that information in the chat as I share information. So as mentioned, NASHBID, we held our annual meeting in Washington, D.C., July 27th through 29th, because everyone loves going to the district in the heat of the summer. And we, in addition to having digital mental health well represented among our amazing sponsors, we also held a panel on artificial intelligence and digital mental health. So you can see here our wonderful panelists and yours truly. So we had Dr. John Toros, who's really considered, I think, one of the leading experts in the US, if not the world, on digital mental health. Me, who's just interested in this topic and gets to do fun things with NASHBID. Steve Appleton from the Global Leadership Exchange, who will also be on the jam upcoming, as will Dr. Toros. Anil Taplial of the EMIC, the International Congress on Digital Mental Health, and Afshin Khoshravi of Trilogy. So we covered a lot. So we got an informative overview on AI, like what it is, how it's evolved over time, what applications are for mental health from Dr. Toros, and his slides are on our website. And then our panelists discussed the benefits as well as the cautions regarding digital mental health. So what's working really well about it, what are the things we should be looking at, concerned about, paying attention to? What do we want state leaders to be thinking about when incorporating digital mental health solutions into their systems? What's ready for implementation now, and the future, what's in the future for artificial intelligence and digital mental health? And our recording of this panel will be available within a few weeks on the NASHBID website. So I'm just giving a little quick overview here because it was an hour-long panel. I think we actually went a little over our time, so I can't possibly fit that into 5 minutes, but hopefully I'll tempt you to check it out. What do we mean by digital mental health? Why should we care about it? So the framework I think we could think about is there a person, service, people using services facing, provider facing, and policymaker facing. So really anything from wellness apps and sites that support population mental health to all the way up to digital therapeutics and technologies that monitor safety on inpatient units, for example, and everything in between that. Then provider facing, things that improve efficiency, reduce administrative burden, more realistic training opportunities, comprehensive quality assurance, decision support, predictive tools, and then data facing for policymakers. So I think about when I directed Maine's Office of Behavioral Health, having more real-time data thanks to technology on things like where are the hotspots for crisis utilization, where are real-time overdose spike alerts in my state. So we should care about all this because people are using this anyway, whether we endorse it, support it, or like it or not. People are using artificial intelligence for emotional support, for example. And so we probably ought to have a better understanding. There are a lot of untested apps and sites out there and examples we've seen of how they can potentially cause harm. So that necessitates us needing to know what are the evaluation standards? What is the difference between a good tool and a potentially harmful tool? And, mainly I think we're interested in these things because we can increase our limited workforce capacity. We can use these resources for upskilling, better tools for decision-making, improving access, and most importantly, improving outcomes. So I think I don't have much time left. So I'll just, again, point you to that resource page, and I'll also, Day will put in the chat. We discussed a little bit in the panel, the White House recently releasing a paper on America's action plan on artificial intelligence and specifically calling out healthcare. So I'll turn it back and look at this. We have a tech corner next. So the Crisis Jam is just on top of all this. Thanks, David.
Thank you so much, Jessica. Let's go to Tina, who's going to keep that discussion going.
Thank you so much, Jessica. You really queued me up. I appreciate it. I'm so inspired by all of the creativity that I've heard today on folks really banding together and finding so many creative solutions to help our communities and folks who are really in need. And we hope that we're contributing to that. So I just wanted to talk a little bit about a new training that we're releasing from our company, Listen. The ethos of our training is practice, 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 and then being able to get expert level feedback to know that the interventions that you're doing are evidence-based, they're positively impacting the community, and then they're supporting providers in really difficult conversations and interactions. So we've partnered with Dr. David Jobs and Samantha Chalker to be able to create this fabulous training on suicide prevention skills. We have 5 different modules that we've partnered with them on, and you can go to the next slide, Karen. We have clinical vignettes that are realistic to the types of folks who might come through. Crisis receiving centers might be sitting in someone's office going through a crisis or experiencing suicidal ideation. So we have realistic clinical vignettes. And then we have, most importantly, the opportunity to practice. So you can go to the next slide and see what that looks like. So folks can record as many responses as they want based on the target skill that they're trying to hit. There's didactic content and videos to help them formulate those skills. And then again, practice, practice, practice is the ethos of this training. Our classification AI provides expert level feedback. And again, we've trained our models based on what human experts have defined as these evidence-based grounded interventions. Folks, learners get feedback on whether or not they were able to hit their target skills. And great question, Stephanie. We use classification AI in our models. So we are coding what has already been said. We're not creating any new content based on artificial intelligence. We're telling you based on what you recorded, were you able to hit the target skill? And then we've also got a supervisor dashboard and platform so folks can see how are my learners doing? How can I encourage them? We always want to keep a human in the loop in the training process to make sure folks are pursuing appropriate professional development, they're getting their skills and needs met, and then when they're working in these fabulous crisis receiving facilities, they're interacting with people, they have the tools and skills that they need to provide compassionate care. So thanks so much for the opportunity. Y'all can always email me, tina@listen.io with any questions.
Tina, thanks so much. So much great content, and you expedited it for our schedule here. Make some more comments in the chat. Stephanie Hepburn, you revisited an article from July, but I'd also encourage you. Tina Orwell is also here lurking. She hasn't jumped in here, although the battle of the bills has been raised several times. I'd love to hear your question for both Tina and Steve as we close out today.
Thanks, David. Actually, that's a great point to get a response from both of them, because my question was really leaning into, actually interviewed Kevin Curtis a while back, and he told me how critical and instrumental it is to have legislators on board who are really spearheading these discussions with commercial payers and state and Medicaid agencies. So I'd love to get both of their responses on what that should look like and what needs to happen, because not everyone has the same buy-in when it comes to mental health.
Senator Orwell, you want to go first?
That is such a great question, and I feel like we're still trying to tackle it in two ways in our state. First, we involved our Office of the Insurance Commission. They have been our partner on this. We had a bill probably 4 years ago that said that the private insurance companies had to provide crisis care and after crisis care. And that really set the stage for these discussions. And then we also in our state have next day appointments, both on the public and private side. So we continue to engage. I just love the conversation on the crisis relief centers, but legislators can start the tone by requiring their coverage of crisis services.
Steve?
Yeah. So, I just know how we did it in Utah, which we knew we needed the commercial payers on board. So I put that in the bill. If, I had one insurance mandate requiring insurance companies to cover mental health for behavioral health people that need services but don't want them in their own hospital. That bill is an insurance mandate. The insurers supported it. If you can get a mandate through, great. But at least dangling that out there as a threat did work for us. But at the end of the day, it's just like locking up firearms. People would rather do it. You'd rather have them do it because they know it's the right thing to do, instead of there's a law and a penalty if I don't do it. So educating them about the benefits is the number one thing, and hopefully bringing them on board voluntarily. But if not, you can always use the big lever of legislation if need be.
Yeah, great.
And when it comes to legislators and getting their buy-in, when I interviewed you, you said something to the effect of, legislators must examine the experiences of their constituents during a crisis. And both of you do a tremendous job at that. But again, that comes back to buy-in. What is a good entry point, whether it's behavioral health leaders, to help push legislators to be open to hearing those discussions and people's experiences?
Well, if I could jump in, I can introduce the perfect bill, but it's the stories that carry the bill. And really working with the community leaders and NAMI and families to come to Olympia and share their stories, because you really have to open a heart, to open a mind, right? And it's very effective.
I like that. What about you, Representative Eliason?
The logo for the Huntsman Mental Health Institute is a heart inside of a head, a mind. And so, yeah, I agree. You have to touch both hearts and minds. We have plenty of data, but when you can get somebody, I named my bill Charlie's bill after a friend who'd been discharged quickly from an emergency room after a crisis with a bad experience. He was willing to share his story. And so you have to approach it from both angles to really move the needle.
Yeah,
I love that. Thank you so much.
Thank you, Stephanie. Thank you, Senator Orwell, for jumping on. And a huge thanks to Chris Santosiero, Paul Galdus, but especially Kevin Curtis and Rep. Steve Eliason for sharing with us the amazing work the Huntsman family, the University of Utah, and others are doing to advance 988 mobile crisis and crisis facility care in Utah. Thank you all. We want to hear more about it as we go. But next week, we're going to hear more about the awareness of 988 and how that's growing from a poll from NAMI and Ipsos with Brandon Graham. In 2 weeks, we'll have the fourth in our series of A Day in the Life focused on follow-up care. Thanks so much for joining us, and we'll see you next